Hello, everyone, and welcome to today's webinar, Importance of Hepatitis B Viral Load to Trigger and Monitor Antiviral Treatment for Chronic HBV Infection. I am Kaylee Bach of Labroots, and I'll be your moderator for today's event. Today's educational web seminar is presented by Labroots and brought to you by Bruker Microbiology and Infection Diagnostics. To learn more about our sponsor, please visit bruker.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have any trouble seeing or hearing the presentation. And with that, I'd like to now welcome our speaker, Edouard TUAILLON, MD, PhD, Professor of Medicine in the Laboratory of Virology in the Department of Infectious Disease at Montpellier University Hospital. Professor TUAILLON, welcome. You may now begin your presentation.
Thank you, Kaylee. So, hello everybody. Thank you. I would like to thank Bruker to invited me for this web conference, and thank you to joining us for this web conference focused on the importance of hepatitis B viral load to trigger and monitor antiviral treatment for chronic hepatitis B virus infection. So the main objective of this presentation is to discuss the importance of HBV DNA in therapeutic decision, and also to discuss the need to improve the access of hepatitis B virus PCR in Africa. So let's start by this first map. It is good to remind the magnitude of the hepatitis B epidemic worldwide. HBV infection is a very large epidemic. It is estimated that the hepatitis B virus infects over 300 million people worldwide. It's good to keep in mind that for HIV, for example, it is estimated that around 40 million people live with HIV and HIV infection. So it's much more for hepatitis B. However, it's important to note that the severity of the infection, of the HBV infection, the risk of adverse outcomes, and the number of deaths directly related to hepatitis B virus infection are not so high. As you can see, there is almost a little bit more than 500,000 deaths related to hepatitis B virus infection. So relatively to the number of people living with hepatitis B infection, it's not so much. It's a very high number, but not so high than, for example, for HIV, for the same number of people. So on this slide, you can see the prevalence of hepatitis B, and you can see that there is a different color and regarding the level of the prevalence, and we can distinguish three categories of countries. The countries with a low prevalence in green, in blue color, and in this case there is less than 2% of prevalence. The second category is the countries with yellow or an orange color, and in this case it's an intermediate, moderate level of HBV prevalence with percent ranging from 2 to 8%, and finally in red you have the countries where the prevalence is high. And as you can see, it's the case of countries in the west and the central part of sub-Saharan Africa. So let's move forward on the burden in Africa. So as you can see in the previous slide, it's really a big problem, a big issue for West and Central Africa today. And it is estimated that approximately 80 million people living with chronic hepatitis B virus infection in Africa. These people, of course, were at risk of death related to the infection, and it is estimated that about 70,000 people will die directly from a cause related to the hepatitis B infection. And among these causes, there is the hepatocarcinoma, cellular carcinoma, the liver cancer, that cause around half of the deaths, and the other half, the other deaths are related to cirrhosis. Finally, it's important to understand that the natural history of hepatitis B infection conduct about 10 to 20% of the people to have a severe outcomes and a death related to the hepatitis B virus infection. So this aspect of the therapeutic decision is very important, because we have to think that by comparison for HIV or hepatitis C virus or tuberculosis, all the people need to be treated. It is not the case for hepatitis B virus infection, since finally a minority, okay, it's a significant minority, but only a minority of people will have adverse outcome related to hepatitis B virus infection. So on the next slide, you have the natural history of hepatitis B. And this natural history is of chronic hepatitis B. This natural history is quite complex, actually. This natural history is characterized by a series of phases that reflects the nature of the interaction between the host and the virus, the hepatitis B virus. More precisely, between the immune system and the hepatitis B virus. Remember that the hepatitis B virus is not cytopathic. In other words, it is not the virus that will destroy directly the cells in the liver, but the immune system, the immune response that will cause liver damage and hepatocyte destruction, not the virus by itself. In some subject, we'll have a strong immune response, a prolonged immune response, and that will cause liver injury. And in other people, the liver injury will be totally absent. So the first phase, as you can see on the slide, the first phase of the natural history is known as the immune tolerance phase. And during this phase, there is a high level of HBV replication, while there is no response, no immune response, and finally, no liver injury. This situation is a sort of anergy, resulting in an absence of liver injury. This phase is characterized is characteristic of the early phase of the infection and of the infection during the childhood, and thereafter we will have the second phase of the infection. This second phase of the natural history of the infection is called the immune clearance phase, and during this phase the immune system will start to react against the virus and against the hepatocytes that are infected. It results from this immune clearance phase two possible outcomes. First, the immune response could be highly efficient, and the viral replication may only persist thereafter this immune clearance phase at a low level without causing liver injury. And this is the best situation, the good outcomes. But the other possibility is that the immune clearance phase lead to a chronic liver injury, that will be established with higher viral replication on a chronic liver injury induced by the immune system. So the best situation is called immune control phase or inactive hepatitis B virus infection. That's the old terminology. And in this case, the virus is controlled and the liver injury is very limited. So you can understand that the treatment will be not necessarily recommended in this case. And the other situation is called chronic active hepatitis B virus infection. And it's the worst phase because the virus replication remains high and induced a chronic liver injury by the immune system. This induced inflammation, necrosis, and a high risk of cirrhosis and liver cancer. Hence, it is easy to understand that the treatment is recommended in persons that are in this special phase of chronic active hepatitis. Thereafter, over the time, the hepatitis B can be resolved and become inactive, and finally people can recover from hepatitis B virus infection, but sometimes the reactivation is possible. So it's a little bit complex, but important to understand that there is a succession of phases, and the treatment is especially needed when there is liver injury, so when there is a phase called chronic active hepatitis. So what about these different phases in Africa? In this very recent study, you can see the results of a very recent study. This is a recent collaborative study that have been performed in sub-Saharan Africa. And the authors have analyzed the situation of persons living in Africa with a chronic hepatitis B virus infection. And you can see the results. First of all, there is only 10%, less than 10% of the people that have been tested positive for HBe antigen. That signifies that less than 10% have this marker. That is an indicator, a marker of the immune tolerant phase or the early phase of the infection. Only 10%. A very large proportion of African people actually that are infected by hepatitis B virus have a low level of HBV replication. And you can see that the median level of HBV DNA in this study, including a very large number of African people, is only 573 international units per ml. That's the median. It's low. It's below the level, and we will later speak about this level, this threshold of 2,000 international units per ml. It's a low level of replication. So a large proportion of people have a low level of HBV replication and actually are in an inactive phase of hepatitis B virus infection. But there is also approximately 15% of people with a cirrhosis, and finally a high risk of liver failure, of liver cancer, and death related to HBV infection. So what is the conclusion with this? In Africa, HBV is a common disease, for sure, but that will be non-lethal for a majority of the people, but potentially very serious for a significant minority of persons. So the idea is to identify and to treat the people that need to be treated and that are at high risk of adverse outcomes. So on this slide, you can see another important aspect of HBV infection. about regarding the genotype. The genotype are also something that we have to take into account. You can see on this map that according to the geographical region, according to the countries, you will not have the same HBV genotype that circulates. And as a consequence, the course of HBV infection will not be exactly the same in Africa, Europe, and Asia. Apart from the environment factor, especially alcohol consumption in Europe and exposure to food molds, especially aflatoxin in Africa, that are associated with a high risk of liver cancer, the genotype play a key role in the natural course of HBV infection. And you can see that there is something special with the West and the Central Africa regions. You can see that the HBV virus in these two regions are mainly genotype E virus. This is quite infrequent in the other part of the world. So there is a special genotype in West and Central Africa. This genotype is predominant and restricted to West Africa and Central Africa. The genotype, the HBV genotype E, can be considered as a neglected genotype because there is very few data about this virus in the literature. You can see on this table that it is possible to distinguish some genotypes that are at higher risk of adverse outcome. For example, the genotype C, and other genotype that have a better prognosis, the genotype B and E. But what about the genotype E? It's written, not determined, unknown. So we have few information to know if this virus is genotype E had a best or an adverse evolution. That start to change because there is some new data about this, but it remains a virus with a low number of data, and many questions remains about this virus. But there is some guidelines. We will start to examine what the international guidelines recommend for the treatments. And of course, these guidelines are not based on data on the genotype E, because there is a lack of data, but mainly on the other genotype. So we have to use the data on the guidelines for the other genotype, but keep in mind that these guidelines are not fully satisfying regarding the care of the genotype E. So we will see the recommendation of the WHO on the EASL, the international recommendation of the WHO on the EASL, that clearly indicates who to treat and who not to treat. There is few differences about these two guidelines, but these two guidelines are very similar. So first at all, for the WHO, who to treat, the people with a cirrhosis, with no doubt when there is a cirrhosis or AST to platelet ratio index. We'll speak later on this ratio. Over 2, then that signifies that there is a fibrosis, and the treatment is recommended. The most frequent situation is the second one, the adults, people over 30 years that have a level of replication over 20,000 international unit per ml, so a moderate to high level of replication, and an abnormal level of ALT, regardless of the HBe antigen status. So when there is some marker of liver injury, even if it's only moderately elevated, and a quite high level of HBV replication, then it's probably a chronic active infection and the people need to be treated. The last point, if we don't have the possibility to test the DNA, we may consider the treatments, but it's less comfortable and it's more difficult to decide if really there is a need to treatment. If there is a cytolysis, an abnormal ALT level, then the treatment can be considered for the WHO. Next slide. Now, who not to treat, but continue to monitor for the WHO. Mainly the persons with an APRI score below 2, so without evidence of cirrhosis or evidence of liver injury, a normal ALT levels, and an HBV DNA level low. Low means below 2,000 international units per ml. So there is a large number of African people that are in this situation, and it's really important to have the PCR results to decide not to treat, but to continue to monitor and to avoid a treatment that could be not necessary. The other point concern people aged below 30 years with especially no cytolysis and a level of HBV DNA between 2 and 20,000 international units per ml. What about the EASL recommendation? The EASL recommendation, as I said previously, are really close to, and we can say similar to the WHO with some small differences. But we have still the same threshold for the HBV DNA, as you can see, the threshold at 2,000 international units per ml. Over this threshold, even if the liver necroinflammation or fibrosis is moderate, there is a recommendation to treat. And if there is a level of HBV DNA over 20 international units per ml, then there is a need to treatment if the ALT is over twofold the normal value. When there is cirrhosis, no question about HBV DNA or cytolysis, there is a need to treatments. And the treatment could be used, could be recommended, but it's not. It's a possibility, just a possibility. If the person were aged over 30 years, have a normal ALT but a quite high HBV DNA, so let's say over 20,000 international units per ml. And also it's interesting to note that patients with a family history of liver cancer or cirrhosis could be also treated. So it's not so simple. It's for sure more complex than for HIV or hepatitis C or tuberculosis, but in all these cases, if you diagnose the infection, you have to treat. In this case, we have to take into account the cirrhosis, the liver injury, of course, the level of HBV replication to decide who to treat and who not to treat. This slide tries to summarize all these recommendations, and we can say that the treatment is not recommended in young people when there is a low level of replication and no liver injury. By contrast, the treatment is indicated with no doubt when there is a high level of replication and a liver injury or a cirrhosis. And the last situation, and we will discuss this point later, is the pregnancy when the mother, the pregnant woman has a level of HBV replication over 200,000 international units to protect the children from children from mother to child transmission of hepatitis B. There is a need to treat during the pregnancy. And the gray zone, let's say that it's the gray zone, treatment could be possibly is indicated possibly when the level is between 2,000 and 20,000 international units per ml. When the patient were still positive for HBe antigen, but with an age over 30 years, and when there is a family history of liver cancer and cirrhosis. Maybe, and last situation is the case where the HBV infection has been acquired at birth, because in this case we know that the adverse outcomes and severe evolution is really more frequent. So maybe if we are sure that the disease, the HBV infection was acquired during the delivery at the very young age, maybe that could be also an indication to treat and to avoid adverse outcome. The two next slides will focus on the two biological parameters that are also important for the decision making. And the first one is the APRI score, based on the IST and the platelet count. And in this really recent study published by the team of Maud Lemoine, the authors were interested to analyze all the data to reevaluate and to optimize the APRI score. The APRI score, the threshold for the APRI score is 2 for the WHO. But the author, using African data, showed that a lower value could be better to use, and based on the estimation, the evaluation, the assessment of the fibrosis and cirrhosis, they used the FibroScan method. Because, of course, the APRI score is a simple method to test the fibrosis, but of course, the reference method is the biopsy, or if you don't use the biopsy, then the FibroScan could be a good alternative. So they use the FibroScan and they compare to the APRI score, which is very easy to perform. And in the field in Africa, of course, most of the physician, the clinician use the APRI score, and they shown that a lower value at 0.65 could be retained to rule in the cirrhosis, and a level of 0.36 could be used to rule out the cirrhosis. So probably it's good to use a lower level for the APRI score to be sure that the person don't need a treatment based of the level of fibrosis. That's the first parameter. And the second parameter is the HBe antigen. So the HBe antigen could be used also for decision making. And HBe antigen can be used especially to decide, as a surrogate marker of HBV DNA, to decide which woman pregnant women need to be treated to avoid the mother-to-child transmission of hepatitis B. In this study that we performed in Burkina Faso with Alice Guinganet, Dr. Alice Guinganet, we have tested a mother with chronic hepatitis B virus infection and their family. And as you know, as you can see on the figure, mother with high value of HBV DNA, namely over the threshold of 200,000 international units per ml, were also positive for HBe antigen, whereas very few mother, one, two, maybe two mother tested negative for HBe antigen, had a high viral load over this threshold. That signifies that this marker is interesting to screen the women that need a prophylaxis during the pregnancy. And in the meta-analysis performed for the WHO under the supervision of Yusuke Shimakawa, and indicate here in the bottom at the bottom of the slide, we conclude that HBe antigen is accurate to identify women with HBV DNA above this threshold, with high sensitivity, but also with a quite low specificity to predict case of immunoprophylaxis failure. That signifies that when HBV DNA is unavailable, we can use HBe antigen to identify the mother at risk of mother-to-child transmission, but this marker is less good, less accurate. The performance are not so good than HBV DNA to evaluate the risk of HBV transmission during the delivery. Okay. Let's move forward now. I would like to have a short discussion on two special situations in the care of HBV treatment, in the care of HBV. First, the treatment discontinuation, the stop of the treatment. We consider, and the easel is clear on this question, the treatment should be prolonged for a very long time when the treatment is initiated. But when to stop, this question remains a subject of debate. Actually, we are sure that the treatment could be maintained in patients with cirrhosis. Stopping the treatment is a possibility, should be envisaged only in patients with at least 3 years of undetectability when using the tenofovir, and in patients that are followed closely with ALT and HBV DNA during the follow-up. And when we stop the treatments, then we have to keep the same threshold at 2,000 international units per ml. And if this threshold is, if the level of replication is over this threshold after the treatment interruption, then the person needs to be treated again. So, as you can see, it's not so easy to decide to stop the treatment. And if the treatment is stopped, then you have to follow the level of replication and the possibility of a reactivation and of a liver injury. The other special situation is the resistance, and we are quite lucky in this case because the recommendation is to recommend a drug with a high barrier to HBV resistance, and that's the case for the tenofovir. The tenofovir is the drug available in Africa, tenofovir disoproxil fumarate. Actually, there is very few cases, maybe no case, or for sure very, very few cases of tenofovir resistance. So the idea is probably not to use the HBV DNA to follow the resistance. So at this moment of the conference, I hope it's clear for you that HBV DNA testing is very important to decide who to treat and who not to treat. However, one of the main difficulty and problem is the availability and access to HBV DNA testing in Africa, and this access should be at a reasonable cost. On this slide, you have a figure that illustrates the poor availability of nucleic acid tests in low-income countries. Nucleic acid tests are generally not available at community and primary care levels. At district levels, point-of-care nucleic acid tests can be available, but generally they have low capacities because it's point-of-care tests, unitary format. And it's often only at the provincial and national level that you can find laboratory assays that can be performed on a large number of tests. And so this poor access is really a problem. Again, with Dr. Alice Gingane in Burkina Faso, we have explored mother with HBV infection. And as you can see in this other study, in the figure, we have represented the cascade of care for hepatitis B virus infection. And there is a major gap in the cascade of care in mother infected by hepatitis B, when the mother have to be tested for HBV DNA. Because mainly of the cost of this assay and on the poor access to laboratory facilities. Thereafter, you can see that there is very few mothers that need to be treated. Only 7.5 of the mothers that have been tested for HBV DNA level need to be treated. So one of the main gap is related to the HBV DNA testing. That's the reason why in the ANRS study group, ANRS Assay 12 working group in France and in African and Asian country, we built a network to do a study for the implementation of a generic HBV assay on open platform, polyvalent platform. The PCR kit used in this study was produced by Biocentric and obtained the CE-IVD regulatory approval. And the objective of the study was to use this PCR on open polyvalent platform in different countries, Asian and African countries, to study the analytical performance, to compare the HBV PCR on open polyvalent platform to the reference assays that were in this study, the Abbott and the Roche system. So regarding the analytical performances, we obtained good results with, before this, so a recall of the objective of the study. So the idea was to test and to implement PCR in low and middle income countries to show that the analytical performance were good, and we performed a comparison, as I said previously, with Abbott and Roche system. And the analytical performance, you can see on this slide that we have good results, good reproducibility, good intra and inter-run reproducibility results, low variation. And we have a good limit of detection, so a good analytical sensitivity with capacity to detect HBV DNA concentration below 100 international units per ml. that was when we used the small volume for extraction. You can also use a large volume of extraction, and then the sensitivity is even better. I will just go quickly on the correlation between the biocentric PCR and the Roche system with this figure, and you can see here the results from Ivory Coast and France, and the correlation between the two methods was high. Next slide, the correlation between Biocentric and Abbott in Thailand and France, with also a high level of correlation. And on the next slide, you have the Bland and Altman comparison for the different laboratories that compare Roche or Abbott with the open polyvalent the PCR on the open polyvalent platform. And you can see that in the 9 sites that perform on that perform this comparison, you have a good agreement between the results with the open polyvalent platform and the results with the Roche and Abbott system. So the global agreement between the PCR were good and satisfying in the different laboratories. So the conclusion regarding the need to base the treatment decision on the HBV DNA. It's clear that HBV DNA in plasma is a crucial factor in determining the need for antiviral treatments. That's clear in the WHO and the EASL guidelines. For people aged over 30 years, when the plasma DNA concentration is over 20,000 international units with an increase of the ALT, then it would be necessary to start the treatment and to maintain for a prolonged period of time the treatments. On the other hand, the treatment is usually not recommended when HBV DNA is less than 2,000 international units with no sign of cirrhosis and a normal ALT value on the different testing. For the mother-to-child transmission, it's very important to try to start the treatment in the mother during the pregnancy when the level is over 200,000 international units per ml. The other part of the conclusions are about access to HBV PCR and HBV DNA testing. Our idea in the INRS group was to show that the open polyvalent platform could contribute to better implement HBV DNA in the field, helping different countries to test and to have a decision-making based on the recommendation, on the guidelines, on the HBV DNA level. In our experience, the biocentric generic HBV PCR was reliable, and we obtained good results for both the detection and the quantification of the HBV DNA. So I would like to thank especially all the INRS team, the study group, Assay 12, and especially my friend Draman Kanya. Draman Kanya is the co-PI of this study in the Burkina Faso, and also all the people in this very efficient network. Thank you for your attention. I'm available for the question now.
All right, wonderful. Well, thank you so much, Professor TUAILLON, for your informative presentation. We will now start the live Q&A portion of the webinar. So if you have a question that you would like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. All right, so let's get started. We've already got some great questions in our queue here, so I'll go ahead and start with this one. This first question asks, in regards to therapeutic success, is it essential to obtain undetectability of HBV DNA?
Yes, that's a good question, because when we start with the treatment, it can take time to reach undetectability. So, and sometimes we do not obtain this desirable undetectability. So first at all, regarding the dynamic of the decay of HBV DNA, that could take time, and we don't have to think that the decrease of the HBV DNA will be as fast as for HIV. So having a decay and during 1 year or 2 years to be undetectable for HBV DNA, it's something normal. And regarding the small proportion of treated person that are really observant, that people that have no problem with the medication and the adherence of the treatments, there is something like 5 or 10% of the person that are treated that will not be undetectable for HBV DNA despite the treatment by tenofovir. Is it a problem? Actually, I would say no, because most of the time the level of HBV DNA will be low, most of the time around 100 international unit per ml, so around the limit of detection of the PCR. Sometimes it's a little bit more, but in whole case, there is generally no liver damage or no sign of liver injury. So I think we don't have to really be worried about this small level of HBV DNA that can persist. That's yeah, I can say this. I think most of the time it's not a problem. Sometimes when it's possible, we had another treatment in addition in Europe, but a part of the clinician don't think that it's necessary. And personally, I think when we have a small level of replication, it's not necessary to add another treatment. Thank you.
Great, thank you. Another question I have for you here. What is the place of HBV PCR in tenofovir interruption strategies?
For sure, the HBV PCR is also important when we decide to stop the treatment, because there is a risk of reactivation. And if possible, it would be good to test, for example, after the treatments of mother during the pregnancy. It's good to try to monitor the HBV DNA to be sure that there is no very high reactivation. And when we decide to stop the treatment after 3 years, for example, it's good also to check if the level of replication remain low, and then we can continue with our treatments. But if there is a very high rebounds, then we have to restart. So it's important to keep the HBV DNA to monitor the treatment interruption.
Great, thank you. Next question here asks, should we fear tenofovir resistance for HBV?
Thank you. this is really a good point with the HBV treatments. As you can see, the treatments of HBV is not so easy to decide. We have to decide who to treat, who not to treat. But when it's decided, when we know that we have to treat, then the treatment is simple because it's based on only one pills per day, and the tolerance is very good. There is a few interaction, few problem with tenofovir, and this is really interesting when we compare with HIV or tuberculosis. There is no clinical problem with the resistance for hepatitis B virus infection. So the issue is to decide who to treat or not, who not to treat, and we need the HBV DNA for this. But when we decide to treat, then it's easy, and we don't have to monitor the HBV resistance in most of the cases.
Great. Now, is there any relationship between HBV genotype and disease outcome?
Yes, of course, there is. That's the idea was to try to point out this issue for sure. The genotype C or D may have a more severe evolution. The problem is for West and Central Africa is to try to better know what is the evolution for the genotype E, because the genotype E is predominant and we have very few data about this genotype. So probably the genotype E is less severe. The infection by genotype E is less severe than other genotypes, but we lack the data are lacking, so it's difficult to say more about this.
Thank you. Now, another question here asks, how frequent shall HBV DNA be tested in HBV treated patients? And what about in non-treated patients as well?
It's quite difficult to respond to this question. Of course, in France, we test HBV. We can say every 6 months, but we may test less frequently. Probably when we decide to treat, I would say it's good to have another HBV DNA quantification the year after the treatment initiation, and then probably we can wait before the next PCR. I would say that one PCR per year would be ideal, but if you perform the PCR every 2 years, it could be good also. If there is no problem, there is no reason to have an efficient the treatment efficient. Also, there is no reason to have a treatment failure based on the tenofovir. If there is a treatment failure, it's probably that the person don't take the pills every day. So I would say ideally one HBV DNA testing during the year after the treatment initiation, and then maybe every year if it's possible, or even each 2 years, it's okay.
Great. Well, we are running a bit short on time, but we do have time for one more question here, so we'll wrap up after this one. And this question asks, how frequent in HIV and HBV co-infections in Africa?
So about the co-infection, the infection is not really more frequent in people living with HIV in Africa. That signifies that actually the HBV infection. So some studies found more frequently HBV in HIV infected people, but many other studies don't find a relationship between the two infections. So we can say that in a country like Burkina Faso, we will have something like 8 or 10% of HIV infected people aged over 30 years that are also infected by hepatitis B virus, and it's the same prevalence than in the general population. So hepatitis B virus, even if the two viruses share the same route of transmission, in Africa, the level of hepatitis B virus infection is almost the same in the general population and in the population HIV infected people. The other point is that thanks to the antiretroviral therapy, the people living with HIV normally should be treated by the tenofovir included in the antiretroviral therapy and have a good treatment for hepatitis B, thanks to the treatments dedicated to HIV infection. So just we have to you have to check that if the HIV infected person is also infected by hepatitis B virus, the tenofovir is included in the backbone of antiretroviral therapy. That's the point, because sometimes there is some people that are with lamivudine 3TC or FTC alone without tenofovir, and it's not high barrier drugs against hepatitis B virus infection. So this is something that need to be controlled sometime.
Wonderful. Well, thank you again, Professor TUAILLON, for your time today and your important research. We would also like to thank Labroots and our sponsor, Bruker Microbiology and Infection Diagnostics, for underwriting today's educational webcast. Now, before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by our speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand, and Labroots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. So until next time, take care, everyone. Goodbye.